Now what about nitroglycerin and isosorbide nitrate? We discussed nitroprusside 2 slides ago. That's done. Now let's talk about 2 more drugs that belong to the nitrovasodilator group, which are nitroglycerin and isosorbide dinitrate, or nitrate. So if we just kind of look at the structures of the 2 molecules, you can already see that there's a bunch of N's and O's in both of these molecules. So there's your nitroglycerin. As you can see, they have very similar structures. There's some N's and O's here, some N's and O's here, N's and O's here, and well, that's not really that important. The important part is you know these have nitroso groups within them. You know this, but let's go through this again. We eventually liberate nitric oxide by both of these molecules being incorporated into someone's bloodstream. The eventual increase in nitric oxide induces the soluble version of guanylyl cyclase to produce more cyclic GMP. The eventual increase in cyclic GMP activates protein kinase G. Protein kinase G phosphorylates a bunch of proteins, particularly the IP3 or inositol triphosphate receptor. Slapping a phosphate onto that means that you inhibit its ability to signal to the sarcoendoplasmic reticulum to release calcium. What's important to know about nitroglycerin and isosorbide dinitrate or nitrate is that they mostly affect venodilation. So as opposed to the other ones, hydralazine was purely precapillary arterioles. The nitroprusside and phenoldiazepam caused a pretty wide systemic arteriolar and venodilation. The nitroglycerin and isosorbide dinitrate or nitrate purely venodilation compared to the other ones. There is a little bit of arteriolar vasodilation, particularly in the distribution of the facial and meningeal arterioles, and that is directly responsible for some of the side effects here, which is the flushing, the headaches, and the dizziness. So you get the flushing because you take the vessel diameter and increase it, the vessel gets closer to the skin surface, and now you have a more prominent vessel lumen closer to the skin surface, and that creates a redness. That is the flushing that you see. Dilation of meningeal arterioles can cause irritation of the meninges, and it causes a headache. And the dizziness can be related to the dilation of the cerebrovasculature, causing hypoperfusion of some elements of the brain, which causes dizziness. Now, in the treatment of angina, acute coronary syndrome, and pulmonary edema, why would it be important to decrease the preload? By giving someone nitroglycerin or isosorbide nitrate and causing venodilation. So the venodilation is essentially just a drop in the preload. So why is that important for someone with these components of increased myocardial oxygen demand and increased transudation of fluid into the pulmonary structures? So in the treatment of angina, acute coronary syndrome, and pulmonary edema, why is it important to decrease the preload by causing venodilation? Remember, venodilation is basically causing a decrease in preload. Well, what happens is that the venodilation causes an increased compliance of the venous vasculature. So if you take a vessel from this diameter to this diameter, it is able to accommodate a much larger volume per unit of pressure. It would take a lot more blood to increase the pressure of this vein compared to filling this vein with the same amount of blood and the pressure you would create by doing that. So essentially we'll have more blood just pooling in these veins. By decreasing the volume of blood returning to the heart, because there's more blood in the veins, we decrease the volume of blood in the ventricles. And that decreases the wall tension. And thus, it decreases the amount of ATP required to pump blood out. And this helps relieve the ischemic-like pain because we decrease the work and the oxygen demand that the heart will require. And pulmonary edema is a rather simple concept you guys already understand. But for completeness, let's quickly discuss and integrate something that we reviewed that is particularly high yield for your Step 1 exam. So think back to the equation that we wrote when we were talking about the capillary microcirculation, where JV equals a filtration constant, our hydrostatic capillary pressure, minus our hydrostatic interstitial pressure, minus oncotic pressure of the capillary, minus the interstitial oncotic pressure. So if someone has pulmonary edema due to increased hydrostatic pressure in the pulmonary microvasculature, there will be an increase in this value, PC, because that's the capillary pressure. There will be an increased driving force of fluid across the capillary wall into the interstitial space, and in the pulmonary microvasculature, these vessels are directly associated with the alveolar air spaces, and that can cause fluid to be in the air spaces, and that's really bad. So how can we relieve some of this hydrostatic pressure? Well, how about relieving some of the pressure by decreasing the volume? Remember, compliance is how much these vessels can accommodate changes in volume per units of pressure. If you decrease the volume being delivered, aka decrease the preload, then you decrease the volume within these vessels, and then therefore you decrease the pressure, which means that you have a less of a driving force, or PC, because there's less pressure within the capillary, and less fluid will be pushed across into the alveolar air spaces and interstitium of the lung parenchyma. This is super high yield because it makes you understand the physiology behind pulmonary edema and the physiology behind augmenting these capillary Starling forces using this equation to save your patient from feeling like they're suffocating. So let's go ahead and talk about the toxicities that are particularly high yield for step 1. So believe it or not, people actually work in industrial settings in which they produce these drugs, and there could be an exposure to inhalation or absorption via the nasal mucosa of these nitrovasodilating agents. So during the work week, Monday through Friday, which we all love, these workers are exposed to these drugs, and they develop a tolerance, so that every day when they're exposed, they don't vasodilate as prominently as you would expect. And remember, they are particularly venodilating instead of vaso, referring to the arteries. But when they go home for the weekend, so Friday night through Sunday night, this tolerance kind of starts to fade. So just think about it as if they're constantly being exposed every time they go to work, they always have the nitric oxide circulating around their system. The nitric oxide is quickly degraded, so if you do not have continued exposure Friday night through Sunday night, you quickly lose the nitric oxide that's circulating around in your blood that you had excess levels of because you were at the workplace. So it's not really per se tolerance, but it's a great way to think about it. So when they come back to work on the next Monday, they're re-exposed to those agents, and they have a vasodilatory response, and then they get the side effects. So again, we vasodilate, drop our blood pressure, and this can lead to a reflex tachycardia. This can lead to hypoperfusion of important structures, such as the brain. This can lead to dilated meningeal arteries, which irritates the meninges and gives you a headache because there's nerve terminals in those meninges. It can give facial artery branch flushing because you increase the diameter of the vessel and making it closer to the superficial skin surface. You get nice and cherry red looks. Another important situation, and probably the most high yield because your patients actually come into the clinic and ask about it. So, have you seen those Viagra or Cialis commercials? They usually end with a couple just hugging it out, and the announcer saying in the closing segments, "Do not take if you are currently taking nitrates for chest pain." Now, why would that be a bad idea? To take a Viagra or Cialis, which are phosphodiesterase inhibitors, so you want an erection, but you're also on nitrates for chest pain. Why is that a bad idea? Well, the nitrovasodilators cause an increase in cyclic GMP. So, these guys cause increase in cyclic GMP, which affects mainly the veins in the situation of nitroglycerin and isosorbide nitrate, but also a slight arteriolar component. We're accumulating cyclic GMP because we want that erection. And we're also accumulating cyclic GMP in the situation of nitroglycerin, but the two different ways. Nitroglycerin and isosorbide nitrate cause induction of guanylyl cyclase to get more cyclic GMP. And Viagra works by inhibiting the breakdown of cyclic GMP, which is done by the phosphodiesterase enzyme. So now we have increased our cyclic GMP by two different mechanisms, and this is incredibly dangerous because we'll get excessive dilation of veins and some arterioles, which can cause an unsafe drop in blood pressure, which means that if you cause a sufficient enough decrease in blood pressure, you actually hypoperfuse important structures such as the brain and the heart, particularly the coronary arteries. So that is why you must listen to that guy at the end of the Viagra commercials who sounds like no one that talks in real life.